Lecture 17 on ventilation and gas exchange. Pulmonary ventilation refers to the actions of breathing, and the actions of breathing are going to involve changes in the volume of the thoracic cavity. This is applying the direct concepts of Boyle's law on the inverse relationship of pressure and volume. As we change the shape of the thoracic cavity, this results in a change in volume. An equal change in volume equals a change in pressure. Shape changes are accomplished by movements of the diaphragm and rib cage. Here we can see the rib cage and how it interconnects with the vertebrae of the vertebral column. Superior movement of the rib cage increases the depth and width of the thoracic cavity, thus increasing its volume. Superior movement of the rib cage indicates inspiration or breathing in. By increasing the volume, we decrease the pressure and allow air to flow down and into the lungs. When the diaphragm contracts, it's going to tense and move inferiorly. This movement, again, will increase the volume of the thoracic cavity, decreasing the pressure within it. All of these actions are going to occur during inspiration. So, at rest, lung pressure and volume. The pressure inside the lungs, or intrapulmonary pressure, and the outside of the lungs, atmospheric, are the same. So here, no movement occurs. You can imagine this as holding still, not breathing in and not breathing out. Expanding the thoracic cavity expands the lungs. By expanding the thoracic cavity, we actually increase the overall volume and decrease its pressure. Here, the parietal pleura is attached to the thoracic wall, the visceral pleura is attached to the lungs, and the fluid that is between these two forms a bond on these layers. If injury occurs here, we have what is called a pneumothorax, where the bond is broken and we cannot properly inflate lungs. This is going to be at rest, where pressure on the outside equals pressure on the inside of the lungs. Here we can see the parietal pleura, the visceral pleura, and the pleural fluid are going to maintain a constant position. The lungs are not increasing or decreasing in size, and therefore there is no air movement occurring. Now, during inspiration or inhalation, the thoracic cavity wall enlarges and increases in volume. This means that the pressure outside is greater than the pressure inside the lungs. And so air will move into the lungs from an area of high pressure to low pressure. So this is the standard pressure gradient. During exhalation, it is simply the opposite. The thoracic cavity will decrease in volume, and therefore the pressure outside is less than the pressure inside the lungs. So air is now forced out from an area of high pressure to low pressure. Here we can see on the left during inhalation. There's a few things that occur as air enters the lungs. First, the diaphragm flattens. This accounts for about 2/3 of the expansion of the thoracic cavity. Movement of the rib cage is going to move up and out, and this will account for the remaining 1/3. The expanding thoracic cavity pulls on the pleural membrane, and intrapleural pressure decreases. The pressure difference, which is higher on the outside of the lungs than it is on the inside of the lungs, causes atmospheric air to move down the pressure gradient and inflate the lungs. On the right, we can see exhalation or expiration, where air is forced out of the lungs. The diaphragm relaxes and bulges upwards. This causes the ribs to move down and in. A combination of the diaphragm and the rib movement are going to reduce the volume of the thoracic cavity. The reduction in volume of the thoracic cavity causes intrapleural cavity pressure to increase. This increase in pressure is going to drive the air down the pressure gradient, moving out of the lungs and into the atmosphere. Exhalation is also helped by the elastic nature of lung tissue. It's stretched like a rubber band, and the lungs immediately want to return to the original shape. When looking at the respiratory muscles involved in breathing, we've talked about two of them already, the diaphragm and the external intercostals. Now, respiratory muscles may be involved with inhalation in the case of inspiratory muscles, or exhalation in the case of expiratory muscles. The primary inspiratory muscles are involved in quiet breathing. They have an active inhalation and a passive exhalation. These would, of course, be the diaphragm and the external intercostals. The diaphragm is about 2/3, 75% of the total movement, and it flattens the floor of the thoracic cavity, increasing its volume. The external intercostals are responsible for roughly 25% and elevate the ribs. Again, this is active inhalation during quiet breathing. Now, sometimes when we inspire, we need to do so more actively. This is the difference between quiet breathing and deeper breathing, or breathing involved in exercise. The accessory inspiratory muscles that are involved in a more deep breathing are going to increase the speed and amount of rib movement, allowing deeper breathing and greater oxygen intake when the demand is greater. Muscles like this would include the sternocleidomastoid, the scalenes, pectoralis minor, and the serratus anterior. So all muscles of the torso and upper rib cage. Here we can see some of those muscles as they are laid out in this diagram. We can of course see the external intercostal muscles and the diaphragm, the two primary inspiratory muscles. The accessory inspiratory muscles listed on the side here are the sternocleidomastoid, which is going to connect to the upper neck and allow the neck to open up to allow air to flow down it. The scalene muscles, which will provide some support to the back of the rib cage and open them up. Pectoralis minor muscle, which would open up the front of the rib cage, and the serratus anterior muscle, which would serve a similar function to the pectoralis minor. Here we can see on the side, from a side view, some of the actions of these inspiratory muscles. Remember that the diaphragm, when it contracts, is going to pull downward. The external intercostal muscles will flex and pull the ribs together, moving upward. We can see that the other muscles of the chest are going to allow the chest to expand out and up, all about increasing the total volume of the thoracic cavity. Now, when exhaling or expiring, there are no primary expiratory muscles when we are passively or quietly exhaling. So remember that the inspiratory muscles are going to be active, where we engage both the diaphragm and the external intercostals and flex the muscles, contract them. And then when we expire, we simply relax them. Here, the elastic forces and gravity reduce the volume of the lungs. However, during deeper breathing and exercise, we use a number of other muscles in order to increase the force and speed within which we can actually expire air. The accessory muscles depress the ribs and push the diaphragm upward, decrease the thoracic cavity volume very quickly, and allow for a greater pressure change and faster airflow out of the lungs. These muscles include the internal intercostals, transverse thoracicus, external obliques, internal obliques, and the rectus abdominis. Here we can see some of the accessory expiratory muscles. Remember that the primary expiratory muscles don't really exist in the same capacity. The diaphragm and external intercostals simply relax during quiet breathing. So these muscles are only involved during deeper breathing or exercise. This is all going to be about shrinking the size of the thoracic cavity, compressing and forcing the diaphragm back upwards into the actual rib cage so that we can decrease the size or decrease the volume of the thoracic cavity in a very rapid way. Here we can see the actions of the muscles. The abdominal muscles will actually pull down and back, whereas the internal intercostals are also going to push the ribs down, and the transverse thoracicus muscle is going to allow the sternum to push back against the lungs. All of this is designed, again, to decrease the overall size of the thoracic cavity, thus decreasing its volume and allowing pressure to flow from high to low, pushing air out of the lungs. In some cases, we can actually puncture this pleura membrane to where we actually go through, and this is going to be from a chest wound, and this will cause a pneumothorax. A pneumothorax is actually going to occur when the thoracic cage is punctured, where we might have a broken rib, sharp object, some sort of infection, and this allows the pleural space to equilibrate with the atmospheric pressure. It also introduces air to the pleural space. When this happens, negative pressures cannot be attained despite expansion of the thoracic cage, and the lung collapses. The right and left lungs are functionally separate, so if we puncture one side, we can still actually breathe in the other side. And this is a sample of that pneumothorax where we actually would need to put a tube in there in order to suck out air and to help equalize pressure until we can seal it up. Now, in normal breathing in a healthy individual, it's pretty easy due to several factors. So it's not just about the movement of the muscles, but in many cases, the actual composition of the lungs. We have two major features to look at with the lungs: compliance and elastance. Pulmonary compliance is the ability of the lungs to stretch during inspiration. And this is also going to look at the amount of pressure that is required to inflate the lungs. So if we have a high compliance, it inflates very easily. But if we have a low compliance, it's going to be very hard to inflate and very stiff. This is influenced by the internal structures of the lungs and its overall surface area. On the back side of the coin, we have pulmonary elastance. This is going to be the ability of the lungs to actually recoil and retain its original shape. This is going to be very important with regards to expiration or breathing out. If we have a very low elastance, we have a hard time expiring. So we're not going to be able to actually exhale as easily by just relaxing. We have to forcefully exhale every time. Here we can see a diagram of high and low compliance. Compliance, remember, is the ease of expansion of the lungs. If we have a greater overall compliance, where compliance becomes too high, this is due to a loss of supporting structures and tissues, and the destruction of alveoli increase compliance. This is typically caused by emphysema, smoking, or inhalation of different particulates. Now, on the low side of the coin, if we're outside of normal lung compliance, this can be caused by arthritis or other skeletal disorders. And it affects the articulations of the ribs and the spinal column, reducing compliance by reducing the elasticity of the chest wall. If compliance gets too low, we get into respiratory distress syndrome. It's caused by inadequate surfactant production. Remember, surfactant is that soapy lipoprotein that prevents the lungs from collapsing and sticking to each other. In this case, if we don't have adequate surfactant production, this leads the alveoli to collapse on exhalation. As a result, we have reduced compliance. I mentioned it already, but emphysema is a chronic progressive condition here. It's where we have high compliance and low elastance because of a loss of elastin fiber. Smoking causes the destruction of these elastic fibers, and it becomes very easy to inflate the lungs, but breathing out is difficult and requires conscious effort to contract the muscles. Now, I said it makes it a little bit easier to inflate the lungs, but in many cases, the inflammation of the airways still makes it very hard to get air going all the way down. So in many cases, you have an exaggerated respiratory movement that occurs and is required to maintain near normal blood oxygenation. In addition to compliance, elastance, and surfactant, airflow is also greatly affected by resistance in the airways. This is very similar to what happens in blood vessels. Remember that as resistance to airflow increases, velocity and flow decrease. Functionally, the most variable source of resistance to airflow in the lungs is in the small, smooth muscle controlled by the bronchioles. The smooth muscle in the bronchioles can be induced to bronchoconstrict, shrink in size, or bronchodilate, open in size. This greatly changes the resistance to airflow. For example, when we have an increase in carbon dioxide in the expired air, this will cause bronchodilation, thus decreasing the resistance to airflow and increasing the ventilation. In many cases, different allergies or other conditions can cause bronchoconstriction, and this is due to histamine from the lung mast cells as a potent bronchoconstrictor. And remember that resistance, if we have bronchoconstriction, it's going to decrease our overall airflow. If we are bronchodilation, we're going to reduce resistance and therefore increase airflow. And in some cases where we have asthma or many of those conditions, there's different medications that help to reduce the inflammation and induce bronchodilation. The following diagram is a spirogram. Spirometry is going to actually be looking at the different volumes of different functions of the lungs. The entire spirogram is going to represent the total lung capacity. And each one of the breaths up is going to be indicated by the line moving higher, and each exhalation is going to be represented by the line moving lower on the spirogram. We're going to be looking at each one of these volumes and how it corresponds to the spirogram. First, looking at some basic pulmonary volumes, we have the tidal volume. This is the smallest volume that we saw. It averages about 500 milliliters for a 70 kilogram or 155 pound male. This is the amount of air moved in or out of the lungs during one cycle of resting breathing. Inspiratory reserve volume is going to be the most amount of air that you can take in above tidal volume, so it's going to be an inhalation. Expiratory reserve volume is the amount of air that you can voluntarily expel beyond the tidal volume exhalation. So your inspiratory reserve and expiratory reserve would be using accessory muscles and show you the deepest capacity of breath that you are capable of. Residual volume would average about 1,200 milliliters, and this is the amount of air left in the lungs after a maximal exhalation, because our lungs never get rid of all the air and totally collapse unless we're dead. And the final volume that we'll talk about here is minimal volume. Now, this is the amount of air in the lungs if they were allowed to collapse, and it can't be measured in a healthy person, so it's simply factored into the total lung volume as an estimate. Now, looking at some respiratory capacities when calculating, and yes, you'll need to be able to calculate these. Inspiratory capacity is a combination of the tidal volume and the inspiratory reserve volume, simply added together. Vital capacity is going to look at the expiratory reserve volume, the tidal volume, and the inspiratory reserve volume, and tell you the most amount of air that your lungs can functionally move. Next, we have, looking at this, the functional, I'm going to skip over FEV1 and move over to functional residual capacity. This is expiratory reserve volume plus our residual volume. And this is going to be the kind of reserve that we have in our ability to move air. And then our total lung capacity is our vital capacity plus residual volume. And this will give us the most amount of air that our lungs have in it at any one time, our total capacity for volume of the lungs. Now let's go back to that middle one, FEV1 and the TP index. FEV1 is the functional expiratory volume in 1 second. So this is the amount of air that you can force out of your lungs in 1 second. Additionally, we can take FEV1, divide it by vital capacity, and then times it by 100, and this gives us our TP index, or the Tufano-Pinally index. This is the percentage of the total volume of air in your lungs that you can force out of your lungs in 1 second, and the index simply puts it on an overall scale in percentile form. An average TP index is somewhere around 80%. So since we've looked at the different volumes, we understand that there is a limit in capacity to our body's ability to actually intake and then exhale air. But in many cases, we need to make different adjustments based upon our metabolic demands and needs. This involves two things. First, our respiratory rate, a number of breaths taken in each minute. A normal adult resting range is between 12 to 18 breaths per minute, and an average for a child is between 18 to 20. Children breathe more simply because they have smaller lungs, so they have a higher overall respiratory rate. The other variable is, of course, tidal volume. We can increase or decrease the amount that we actually intake when we breathe, and we factor in respiratory rate together, and then we get our overall respiratory minute volume. Our respiratory minute volume is going to be the volume of air that we move per minute. This equals the breaths per minute multiplied by the tidal volume. Now there's a variation in either factor, and a variation in either factor will of course affect this overall respiratory minute volume. If we have an increase in respiratory rate, it will drive that respiratory minute volume up. If we have an increase in tidal volume, it will of course drive that respiratory minute volume up. At rest, we average about 6 liters of air per minute. This is simply a diagram showing you how those two variables coincide together. Our respiratory rate is our breaths per minute, and our tidal volume, remember, is the amount of air moved with each breath. Multiply these together and we get our respiratory minute volume, which is the volume of air moved each minute. Alveolar ventilation is the amount of air reaching the alveoli each minute. Now, it's going to be similar to the respiratory minute volume, but it will always be less than the respiratory minute volume. And this is because some air never reaches the alveoli, but remains in the conducting portion of the lungs. We know this as the anatomical dead space. At rest, this averages about 150 milliliters in an adult male, 155 pounds. The air reaching the alveoli is always a mixture of used air and freshly inhaled air. So there's less oxygen and more carbon dioxide in alveolar air compared to atmospheric air. So to calculate this, it's going to be similar to that respiratory minute volume. But first, we need to take tidal volume and subtract that 150 milliliters of dead space. Then we can multiply it to the ventilatory rate to get alveolar ventilation. This is a diagram showing you the air in the conducting portion of the respiratory system and then the alveoli, the air in the alveoli, which would actually be a little bit more, which would then contain the oxygen coming in. So the red that you see is always going to have some kind of anatomical dead space air in it. So it's always going to be a mixture of this air. Now we're going to be looking at gas exchange and breaking this into both external respiration, which occurs between the alveoli and the blood, and internal respiration, which occurs between the blood and the tissue. We'll start with external respiration in the lungs. Exchange of gases across the alveolar surface is influenced by 5 factors. Factor 1, the concentration gradient of the gases, where a larger concentration gradient equals a faster rate of diffusion. 2, available surface area. So the greater overall surface area that we have, that means that we can have a faster rate of exchange. We can decrease this with fibrotic scars or pneumonia. A decreased surface area means that we're going to have a slower or poorer exchange rate. 3, membrane thickness. Membrane thickness can increase if we have scarring. Now remember that the thickness of the membrane is going to dictate distance. If a distance is greater, the rate of diffusion will go down. 4, diffusion distance, as I just mentioned. Diffusion distance can be influenced by pneumonia or the alveoli partially filling with water. This is going to cause interference and thus decrease the rate of diffusion. And finally, 5, blood flow velocity. How much time is allowed for the exchange? This is going to be the residence time of the red blood cell as it enters into the capillaries. So normally, surface area, membrane thickness, diffusion distance, and blood velocity are maintained relatively constant through different factors of homeostasis. So exchange is primarily driven by the concentration gradient of gases. Here we can see in arriving deoxygenated blood, the pressure of oxygen is 40 millimeters of mercury. In the alveoli, it's 100. So that means oxygen will move from the alveoli and diffuse into the blood. Carbon dioxide is somewhat the opposite. In the arriving deoxygenated blood, the pressure of carbon dioxide is 45 millimeters of mercury. In alveoli, it's 40 millimeters of mercury. This means it favors diffusion from the alveoli to the blood. Here we can see a diagram of external respiration of blood flow of the capillary in the alveoli. Blood will flow in from the pulmonary artery where the oxygen is lower and the CO2 is higher. And we can see that. Pressure of oxygen 40, exchanging with 100. And then the pressure of CO2 is 45, exchanging with 40, to where we actually leave going through the pulmonary vein as it exits the pulmonary capillary where we have oxygenated blood, with the pressure of oxygen being 100 and the pressure of CO2 being 40. Now, Looking at internal respiration, this is going to be between the blood and the tissue. Oxygen in the arriving deoxygenated blood is 95 millimeters of mercury. Now, this is dropped from the 100 that we had when we left the pulmonary vein, and this is because it mixes with venous blood from the conducting passageways of the lungs. So because that blood is re-entering systemic circulation, it's going to have a slight drop in oxygen concentration. In the interstitial fluid, the pressure of oxygen is going to be 40 millimeters of mercury. This favors diffusion from the blood into the tissues. Carbon dioxide, again, is going to be the opposite. In arriving oxygenated blood, the pressure of CO2 is 40 millimeters of mercury. In interstitial fluid, it's 45. That means carbon dioxide will diffuse into the blood from the tissues. Here we can see the diagram of internal respiration, where the pressure of oxygen going from high to low drives that 95 into the 40. Conversely, CO2, which is of higher pressure in the tissue, is going to drive from the 45 to the 40 as it leaves into the veins. Now, like I said before, the primary driving force behind the overall exchange of gases is the concentration gradient. And this is some fascinating stuff, because when we look at how this works, it shows you how important our overall altitude is. Now, the pressure of atmosphere at sea level is 760 millimeters of mercury. That means the pressure of oxygen is 160. So this makes exchange of gases very easy. Now let's go for a climb on Everest. Everest is 8,850 meters up. That means the overall atmospheric pressure is only 250 millimeters of mercury. So the pressure of oxygen is going to be 52.5. If we have mild water vapor, that can drop down to 42.6. This shows you how that pressure has now dropped drastically to where we cannot maintain that same gradient that we had in our lungs and will therefore have poor exchange. When looking at your lecture notes, I've also provided you an example of Denver. Denver, Colorado is going to be the quote mile high state or mile high city, and it's going to have a pressure of oxygen of 132 millimeters of mercury due to the lower atmospheric pressure. Now, this difference in pressure is going to make it more difficult to breathe because that overall drop is going to affect the concentration gradient. So this is going to result in hypoxia. Hypoxia is lower overall levels of oxygen, and that increases the amount of carbon dioxide levels, known as hypercapnia, in the actual tissue. So really important to kind of note there is how altitude affects your overall ability to breathe. The limit seems to be where altitude sickness comes in is right around 10,000 feet up. Good example of that would be Cusco, the city in Peru. And there's going to be a few other places in the world, of course, that have this.